There is a term called hemodynamic monitoring basic, and there is a term called hemodynamic monitoring advanced. So what is your understanding about advanced hemodynamic monitoring? I just want to know. Monitoring some cardiac output using some fancy machines. The whole difference is how you are applying it. So it is you what makes the difference. So there is it not doesn't depend on the machine. It is the person who is performing the hemodynamic monitoring and who is actually monitoring. So intelligence of the doctor decides advanced hemodynamic monitoring. So hope I'll be able to make you understand this. So again, we don't have time to go into very great details of the hemodynamic monitoring. I'll try to ask some questions. Let's see this. So we had a 56-year-old lady, diabetic hypertensive, who had an old CVA, presented to us with evidence of some poor oral intake, low-grade fever, and now here she is unresponsive. Okay. On examination, she is medium built. Weight is around 65 kg. Extremities are cold. जो चीज मैंने this I have made it in a different color. Take a note of this. Extremities are cold. There is a grade 4 mottling. Are you aware of mottling score? Do you see mottling regularly? Yes. So mottling is the patchy discoloration of the skin. A person of my skin tone, you may not be able to see mottling, but a slightly fairer person you can see, and it's a useful marker. So if mottling is seen, first where? In the knee. If you don't see any mottling in the kneecap, then the mottling score is 0. If you see a coin-shaped patch in the center of the kneecap, then is 1. If it extends up to the kneecap edge, then it is 2. If it up to the thigh, mid thigh, then it is 3. If up to the groin, it is 4, and beyond is okay. So this lady has got grade 4 because it has crossed the mid thigh. So this is okay. Heart rate is 124, BP is 70 millimeter, marker is systolic. आपको सिर्फ सिस्टोलिक ही मिल रहा है, डायस्टोलिक का पता नहीं है. Next supple, planters negative. We see this because unresponsive patients. Other system examination is not that bad. ABG showed a base excess of -16, lactate of 8.4, and RBS of 88. We need to do an RBS because patient is unresponsive. So what do you think? Looks like a septic shock, isn't it? Looks like in shock, not because the blood pressure is low, but because extremities are cold. There is a grade 4 mottling, there is a high lactate, and there is a base excess of -16, not because of blood pressure. So my question is to you all, what is the next best step in the management of these patients? Do you want to give 2 liters of 0.9% saline over the next 3 hours? Who wants to give 250 ml of ringal lactate over the 15-20 minutes? Who wants to start norepinephrine infusion immediately? Who goes for 4? I mean both option 2 and 3, and who goes for both option 1 and 3? एक का फेवर में कौन है? बुली लगाओ, हाथ उठाओ. Okay, so you want to go for 30 ml per kg body weight as per the surviving sepsis campaign guideline. Okay. Who wants to go for 250 ml of ringal lactate, around 4 ml per kg body weight? Okay. Who wants to start norepinephrine? Who wants both 2 and 3? Who wants both 1 and 3? You want 1 and 3. Okay. So let's see indications for vasopressors. Why do you give vasopressors? If our myocardial perfusion depends on diastolic blood pressure. If the patient's diastolic blood pressure is less than 50 millimeter of mercury, which we expect, this guy has got a systolic blood pressure of 70 and diastolic is not palpable. So it's likely that his diastolic blood pressure is very low. Second, if there is evidence of extreme vasodilatation. And how do you know the extreme vasodilatation? The difference between systolic pressure and diastolic pressure is very high. I don't have any exact number, maybe around 50 millimeter mercury or more. or if there is something called diastolic shock index, which is nothing but the heart rate divided by diastolic blood pressure. If the diastolic shock index is more than 2.3, then it is a time that you should start the vasopressors. And why vasopressor? Which vasopressor? Norepinephrine. Why norepinephrine? Because norepinephrine can actually produce venoconstriction. Why do you give fluid? You give fluid to increase the stress volume. You increase the mean systemic filling pressure. And if you can constrict the veins, you also can produce increase in the mean systemic filling pressure. So you can actually indirectly increase the venous return and increase the cardiac output. Thirdly, if you have given at least 1 to 2 liters of fluid, then also you can start the vasopressors, because that can reduce the cumulative fluid balance. So ये patient में norepinephrine start करना है. There is no doubt about it. Now coming to the 30 ml per kg body weight, I think this particular recommendation of survival sepsis guideline has got no at all evidence. It is absolutely nothing, no evidence. It's a zero evidence. So only evidence we have from pharmacokinetic study of fluids is you have to give minimum of 4 ml per kg body weight. This is a study by Hallman, Aya and et al., where you have seen if you want to challenge the system, give at least 4 ml per kg body weight. So an original description of fluids in way back in 1842 by Thomas Later, that says you give little fluid and see the patient respond. Otherwise you will end up in fluid overload. So I think the answer should be 1 and 2 and 3. 4 ml per kg body weight plus norepinephrine. Why RL? ये ना बाद में करें. ओके, लैक्टेट RL से लैक्टेट नहीं बढ़ता है. ओके, this is absolutely misconception. Second misconception, lactate is actually protective for our body. When our body is in hypoperfused stage, brain gets its energy from lactate, and lactate is very important. So even if lactate is just a marker, it doesn't harm our body. Alright, so ringal lactate is a so-called balanced salt solution, and it is preferred. And since this is not the right time to talk about this, maybe at tea time we can discuss. Who has asked me this question? Why lactate? You. We can discuss it outside. ये तो गोविंद सर नाराज हो जाएंगे. Okay. So 46-year-old female, diabetes, presented with septic shock, pyelonephritis. On examination, he is drowsy but arousable. You again highlighted things. See, look at the blood pressure, 94 by 52, map of 66. Look at the capillary refill time. This is how you are supposed to check the capillary refill time with a glass slide. Compress it for 10 seconds and release and see how much time it takes. Do you measure capillary refill time? This is an advanced hemodynamic monitoring tool, not a cardiac output monitoring. Lactate of 6 millimole per liter, and she was started on norepinephrine infusion, and femoral line and subclavian venous line is in place, right? So what is the next best step? So what do you think? This is septic shock? Okay. What is the next best step to restore the tissue perfusion in this patient? Give further bolus of 500 ml of ringal lactate. Increase vasopressor dose. Perform passive leg raising for fluid responsiveness before further fluid bolus. Measure CVP and further fluid if the CVP is less than 8. And look for pulse pressure variation to decide further fluid infusion. Who is in favor of going for 500 ml of ringal lactate? If you don't want to give ringal lactate, give saline. Who is in favor of 500 ml of saline? Or plasma light or stirofundin or whatever you want. Who wants to check fluid responsiveness in this patient? This lady has already been given 1500 ml of fluid. Do you just want to give fluid without checking for fluid responsiveness? So do you agree with me that we need to go for some fluid responsiveness? Yes or no? Yes. I want a loud yes. Yes. Great. So if you want to see fluid responsiveness, what should be the best fluid responsiveness test? Do you want to go for a CVP? It's a static parameter, so we no longer go for PLR. Great. Why not PPV, pulse pressure variation? Because nothing has been, yes, there is nothing has been mentioned about her mechanical ventilation status. Looks like she is in spontaneously breathing. So just to, I often ask in the exams students about the PLR. How do you do it? But unfortunately, in 50% of the times, I get very varied and interesting answers. So I would like you to, first question is, what do you do? You change the bed position from 45-degree head up to 45-degree leg up. And you do it not manually. क्या होगा मैन्युअली करोगे सिंपैथेटिक ओवर एक्टिविटी होगा एंड यू विल गेट योर रिजल्ट यू आर नॉट सपोज टू टच द पेशेंट you are not supposed to do any suctioning, no pain, nothing. So then no, okay. So this is important. What do you look for? I get varied answer. Sir, I'll go for pulse pressure. I'll see the pulse pressure variation and see. So you actually look for cardiac output. And if you do not have any cardiac output, then you look for surrogate. What are the surrogates? What do you have easily? Nowadays we do ultrasound. So we can see a VTI for doing the things. Or if the patient is intubated, then you can go for a ETCO2. These are valid. If you do not have anything, then you can go for pulse pressure. But the sensitivity and specificity is much lower. Okay? So preferably it is a cardiac output. We want to see a 10% increase in the cardiac output or a 10% increase in the aortic blood flow or VTI, or we go for a 5% increase in the ETCO2. These are the valid things. If you do not have one, then you go for pulse pressure. 10% increase in the pulse pressure, but no pulse pressure variation. What do you want to see? Sir, I will see a reduction in the pulse pressure variation. That's probably not the right answer. Alright? But it's not all. There are different advantages and limitations of passive leg raising. First of all, advantages: it is valid in spontaneously breathing patient, as you rightly said. It is valid in arrhythmias. It is valid in low tidal volume ventilation. It is valid in low lung compliance. But there are limitations. There is a need for real-time cardiac output monitoring, which may not be available in all the places. If the patient is on high dose vasopressor, veins are all constricted. There is very little blood available in the lower pelvis and the lower limbs. So it may not be the appropriate measure. Raised intra-abdominal pressure, it may not be validated. Unstable spine and pelvis, it is contraindicated. In patients with traumatic brain injury and evidence of raised intracranial pressure or raised intraocular pressure, it is contraindicated. Remember these few slides. Okay? You all know this, why this pulse pressure variation is, why this variation happens. Heart-lung interaction, we all know it. What happens during inspiration, positive pressure breathing? There is a squeezing of the pulmonary veins. And at the same time, because the right ventricular filling is less, so left ventricle will increase in size. What we call the parallel interdependence. So left ventricular preload is increased because of two reasons. One, because of the parallel interdependence, the LV cavity size is big. RV छोटा हो गया, LV बड़ा होना है. At the same time, you get a pulmonary venous is squeezed. So you get an increase in the left ventricular preload. If the left ventricular preload is increased, obviously you are supposed to see a rise in the pulse pressure, rise in the stroke volume, and rise in the systolic pressure. So this happens during positive pressure inspiration. After 3 to 4 beats, now there is something called interdependence. They are in series, the RV and LV. After 3 to 4 beats, since RV output has gone down, the LV output also will go down. And because of that, there will be a fall or drop in the pulse pressure, systolic pressure and stroke volume. So these are the differences. Now tell me one thing. If your patient is in pulmonary edema, the pulmonary veins mein fluid will be more, isn't it? So you will get a falsely high pulse pressure variation, isn't it? Yes or no? Squeezing effect of the pulmonary vein, you will get a more cardiac preload and will have a falsely high delta high. So there are a lot of limitations of pulse pressure variation, stroke volume variation and systolic pressure variation, and you have to remember them by heart. So these are the conditions where you will get false positive PPV, SBV and SPV. So spontaneously breathing patients, because transpiratory pressure swings are different, so we'll get its arrhythmias, because RR intervals are different, so we'll get different stroke volume variation. Intra-abdominal pressure high, again you'll get a false positive result. RV failure, you'll get false positive result. Severe LV dysfunction, as I told earlier, it will be false positive. Where you'll get false negative? Where there is a low tidal volume ventilation or the lung compliance is very, very low, because it will not be transmitted to the pleura. The pressure will not be transmitted to the pleura. Open chest and a very high respiratory rate. Sometimes in ARDS ventilation and a patient with H1N1 pneumonia, and Chitra was talking about the pregnant lady. How many of you have seen pregnant lady with H1N1 pneumonia? We were unlucky enough in 2009, where we have seen lot, and we have seen lot of death also. So they used to have bradycardia and very high respiratory rate, and to maintain the CO2 you tend to give more than 35 respiratory rate. So here you will get a false negative PPV SBV. Clear? So let's go to the next case. Are you with me? Yes? So let's come back from septic shock to something else. This 34-year-old male presented to us with polytrauma, TBI, chest trauma, ICDD in place, hemoperitorium, bowel resection with ileostomy. On day 5, he is febrile, tachycardic with atrial fibrillation. ABP is 84 by 46 mm of mercury. SpO2 is 95% on mechanical ventilation, 40% FiO2 and PEEP of 5. Do you agree with this PEEP of 5 strategy? Though this is not the lecture. So abdominal pressure is 30 mm of mercury, intra-abdominal pressure, and urine output is only 30 ml in last 6 hours. So do you agree with me that this patient has got abdominal compartment syndrome? Yes. And if there is an abdominal compartment syndrome with a IAP of 30, what should be the PEEP? Is it 5 is enough? It should be more. Alright. Anyway, let's come to the hemodynamic monitoring. So this patient has got a base excess of -8, lactate of 4.6. Somebody has given 500, because somebody is very fond of saline, so he has given 500 ml of saline, just for a change, okay? So what is the next best way to look for the fluid responsiveness in this patient? Beta, this is the way examiners will ask you questions, okay? So these are the, now you tell me, is patient mein what is the best way? Is it central venous pressure? Is it a universal no? Okay. SVC collapsibility. SVC stands for superior vena cava. You can go for a transesophageal echocardiography and see the superior vena cava collapsibility. Do you think it is feasible in this patient? Abdominal compartment feasible नहीं है, valid नहीं है, because this patient is in atrial fibrillation. All patients और SPV, PPV सारे चीजें के साथ SVC collapsibility and IVC distensibility also is not valid in the patients with cardiac arrhythmias. So it's not valid. Pulse pressure variation, not valid. Passive leg raising and look for 10% increase in BTI. एक तो लेग रेजिंग नहीं कर सकते, दूसरा बीटीआई देखना बहुत डिफिकल्ट होगा, एब्डोमेन खुला हुआ है. ओके, सो पैसिव लेग रेजिंग इज TBI, it is absolute contraindication, and intra-abdominal pressure, it is relative contraindication. So what we are left with is and expiratory occlusion pressure, and you all know it. So what do you do? You press you have seen the end expiratory pause button of your ventilator for 15 seconds. So as soon as you interrupt the positive pressure, what will happen? The preload will increase, the pressure will increase, the cardiac output will increase. What do you look for? You look for again cardiac output or surrogate. Here, unlike the passive leg raising, increase in the pulse pressure by 5% is validated. Remember this word. Unlike the passive leg raising, where the increase in the pulse pressure is not validated, and expiratory occlusion, increase in pulse pressure by 5% is validated as a FR positive. I suggest you to do two things. Whenever you do an end expiratory occlusion, also do an end inspiratory occlusion. ठीक है बेटा? When you in end expiratory occlusion, you expect a rise in the cardiac output. In the end inspiratory occlusion, you expect a decrease in the cardiac output. If both the tests are positive, then you can say this patient is fluid responsive. So this is a good test, but there are advantages and there are limitations. Advantages: it is valid in low tidal volume ventilation, valid in low lung compliance. You can use pulse pressure. It is valid in arrhythmias. But disadvantages: you can't do it in a patient who is not ventilated. Can you do it? पहले हम इंटूबेट करेंगे, एंड एक्सपिरेटरी ऑक्सीजन करेंगे, फिर एक्सटूबेट कर देंगे. नहीं, ऐसा नहीं हो सकता है. Rapidly, the patient who is breathing very rapidly, probably they will not be able to tolerate it. So it's a limitation. Case scenario. I have time, Anand? Okay. So 42-year-old male, chronic liver disease, pneumonia and septic shock. On examination, heart rate is 132, ABP 100/52. बेटा बाय द वे पिछले पेशेंट में मैंने सलाइन इसलिए दिया था कि वो TBI था, ट्रॉमेटिक ब्रेन इंजरी, और कोई कारण नहीं रहा, अदरवाइज मैं रिंगर ही दूंगा. So here you see grade 5 bottling. See, even beyond the inguinal ligament, there is a mottling. Grade 5 mottling, very bad prognosis. CRT is 8 seconds, lactate is 6, intubated, lung protective ventilation. SpO2 90% on FiO2, SpO2 90% with a FiO2 of 70%, PEEP of 12, and he has already, ये उल्टा कैसे हो गया पता नहीं चला. चलो, तो तुमको समझ में आ रहा है ना? बस ठीक है. उल्टा भी समझ में आ रहा है ना? हाँ ठीक है, उल्टा हो गया. So patient is already been given 1500 ml of plasmalite. Why we have given plasmalite? Here probably I will not give Renga lactate because this is a child PU class C. So plasmalite can be given. Otherwise, norepinephrine already on 10 microgram per minute. Now the question is, have you seen the? I hope you could appreciate this stupid ultrasound. There is a B profile and there is some pleural effusion. Okay. So question is, what is the next best step in the hemodynamic optimization of this patient? Do you want to give 250 ml of 5% albumin bolus? Yes or no? Why? Yes? So patient is fluid intolerant. Okay. 500 ml of plasmalite if end expiratory occlusion test shows fluid responsiveness. Great. Increase norepinephrine dose targeting higher MAP. Yes. Add vasopressin. Dobutamine. Okay. So okay, that's fine. So there is a question of fluid intolerance. If the patient, there is a possibility of harm to fluid, please do not give fluid. I will not go into the details because of shortage of time. Now we have a lot of things to be done. Clinical, echocardiography, lung ultrasound, there is something called venous access ultrasound. All these things can help us in deciding whether the patient is fluid tolerant or not. If the patient is not fluid tolerant, even if the patient is fluid responsive, please do not give fluid. So these are part of hemodynamic monitoring. Now, how do you optimize the MAP, mean arterial pressure? So SSC guideline says 65, but 65 is not golden rule. You know, 65 हो गया तो हो गया. Now, some patients may require higher, some patients may require even a lower MAP. So there are two large studies. One study called sepsis pump study, where they study higher MAP versus lower MAP. and they could not find any difference except in patients who has got pre-existing hypertension, where they could find that RRT requirement has gone down. There is a 65 study where they could find a lower pressure is as good as a higher pressure, lower pressure of 60 to 65 in elderlies particularly. So I suggest this algorithm. So initial BP 60 to 65, but always remember DBP should be more than 50. If the patient perfusion is maintained with this target, continue with this. But if the patient remains hypoperfused, CRT is prolonged like in our patient, then you go for something called vasopressor challenge. So you increase your norepinephrine dose in such a way so that your mean arterial pressure goes to 80 to 85. Okay? Why this 80 to 85? Because in sepsis pump study, 80 to 85 was the higher MAP group. And now you reassess the patient. If your patient, after reassessment, your patient's perfusion improves, you continue with the 80 to 85, the revised MAP target. If the perfusion does not improve, you go back to your original 65 or 70, whatever the pressure was. Is it clear? So vasopressor challenge, this is been now validated by the Andromeda shock study. Okay, when to use second vasopressor? The only evidence we have is from the VAS study, where they have seen patients who were on a norepinephrine dose of between 5 to 14 microgram per minute. If you start vasopressin, there is a improves in the mortality. So if your blood pressure, if your patient is requiring norepinephrine beyond this 5 to 14 microgram per minute, start the second dose vasopressin, and preferably a vasopressin or an adrenaline. What about inotrop? Again, if you can see by echocardiography, the LV systolic function is poor, along with a VTI of less than 18, start dobutamine. If the SCVO2 is less than 70%, then also you can start this thing. Or there is something called inotropic challenge. If your fluid is optimized, vasopressor is optimized, still the patient is hypoperfused, you can give a challenge called inotropic challenge, where you can use a 5 microgram per minute of per kg per minute of dobutamine and see the perfusion improvement or not. So again, this is validated by the Andromeda shock trial published in JAMA in 2019. All of you should read this paper. I think this is the best paper of critical care in last 20 years. So my quick last slide, 64-year-old female presented with uncontrolled diabetes, hypertension. She has been resuscitated after 6 hours resuscitation. Her extremities are warm, CRT is less than 3 seconds, but lactate is still high. Though initial value was 6.8, but it has gone down. ABP is maintained with a norepinephrine and vasopressin infusion. She has passed some urine, 650 ml in last 6 hours. So this is the CT scan which shows a left-sided pyelonephritis, and now this patient is planned for a DJ stenting. Now my question is, what is the next best step for resuscitating this patient? Would you like to give more fluid if the patient is fluid responsive? Would you like to go for dobutamine if the SCVO2 is less than 70? Would you like to stop vasopressin, or would you like to stop resuscitation altogether? Anybody in favor of stopping the resuscitation altogether? Do you think your resuscitation target has been achieved? Patient is arousable, extremities are warm, CRT is less than 3 seconds. Why do you want to go for further resuscitation? Your target is achieved. Lactate is going down. From 6.8 it has gone down to 4.8. Why do you want to give more fluid? You don't have to go for anything. And this has been confirmed by this great study, by Andromeda shock study. And they have shown by targeting a CRT targeted resuscitation can achieve a numerical improvement in 28-day mortality, and a definite improvement in the organ score at 72 hours, and the decrease in the resuscitation fluid at 8 hours. So CRT targeted resuscitation is good. So my dear friends, ladies and gentlemen, I believe advanced thinking is what is more important, not advanced technology. Your thinking is important. You are doing advanced hemodynamic monitoring not by fancy machine, by yourself. So it is the intelligent, not artificial intelligent, real intelligent doctors with vigilant doctors who can acquire the data, interpret the data in appropriate context, and can ask right clinical question in appropriate setting. What are the 3 questions you ask all the time? Is there any evidence of hypoperfusion? If there is evidence of hypoperfusion, what are the things which can improve the hypoperfusion? Is it a fluid? Is it vasopressor? Or is it inotrope? These are the only 3 options you have. And 4th one is probably blood. Which one to give? And once you have given this, has the hypoperfusion state has resolved or not? That's advanced hemodynamic monitoring. So thank you very much, and read this book. It's a nice book. Any question? If